Dr. Paul Giboney is the Associate Chief Medical Officer for the second largest public health system in the United States, the Los Angeles County Department of Health Services. In this role, he seeks to leverage innovative technologies and care delivery systems to improve the quality of and access to health services. He oversees the LADHS e-consult program, which has conducted over 1.2 million consultations and has transformed specialty care access for more than 5,000 healthcare providers seeking assistance in 65 specialty services. And performance improvement programs like PRIME and QIP, he directs LADHS's patient care enhancements in over 100 projects that touch on every area of the healthcare system. He has served on the National Quality Forum Telehealth Committee and is currently on the board of directors for the California Healthcare Safety Net Institute. Before joining LADHS, he spent more than 10 years in clinical care and leadership at 2 Los Angeles area community health centers. He is a graduate of Northwestern University Medical School and completed his training in family medicine and served as a chief resident at John St. Peter Smith Hospital in Fort Worth, Texas. He is a practicing provider who currently sees adult and pediatric patients at the H. Claude Hudson Comprehensive Health Center. Is there anything else you'd like to add to that, Dr. Giboney?
No, that's great, Phoebe. Thank you.
Good. All right. So if there's nothing else, I'll just kind of start going off this nice list of questions we've got. What inspired you to pursue your particular path within medicine?
So what I'm going to do is I've taken a look at all the questions, and I'll try to, most of them we can go in order, but some of them I may overlap some answers or throw in some answers for others. Just to let you all know, I was the class of '96. So I was there during the Bulls championship runs. So I went to medical school. No other doctors in my family. And I went to medical school primarily just because I was interested in using my career to serve people that were vulnerable populations, people living in poverty. But at the time I went to Northwestern, I didn't know what specialty I might serve them in or where I might serve them. At that point, I had some overseas experience in Africa and Honduras. I had some exposure to rural America. And of course, I'm born and raised in Los Angeles. And so I had a little bit of contact with the urban part. And so as I went through medical school, I kind of began to ask myself, first of all, what do I love in terms of medicine? And what am I passionate about? And is that a passion that can carry me, for an entire career? And as I went through all of my rotations, I found that I loved all of them and did well in all of them. I was very procedurally adept. I loved the ICU. I loved the medical wards. And believe it or not, I ended up coming down to the choice between family medicine or trauma surgery. And you might think those are like polar opposites. But in fact, they actually hit both on some of my things. Trauma surgery was something I had already shown I was good at. I liked the activity in the trauma bay. I liked following the patients up to the ICU. As a trauma surgeon, I could serve poor people in big trauma centers in the inner city. And in family medicine, I found that I liked it all. And ultimately what gave me kind of the nudge, I guess you could say, towards family medicine was, at that point I was still deciding whether or not I was going to go into a third world country, into small town America, or into the inner city. And I really saw that family medicine provided a path to be a doctor who could enter a community and offer the broadest amount of access to care for vulnerable populations. And so I ended up choosing family medicine and haven't looked back since. I think one of the other things I also kind of asked myself was, I want my career to be something that I'm passionate and excited about all of my career. And I could picture myself as a 40-year-old or even 50-year-old trauma surgeon I had a hard time picturing myself as a 55-year-old or 60-year-old trauma surgeon. And that was just, I kind of knew where my passions lie. And so as you can see from kind of my career path in terms of moving into both patient care and leadership simultaneously, that would have been harder to do if I had invested all those years in trauma surgery. So I'm really glad I'm a family doc. I love that. It's served, I believe, my patients and me well.
Kind of going next, I think a good question is, what does your typical week look like?
Yeah, so for the first 10, 11 years of my career, I was 70 to 80% clinical. I saw patients most of the time, all week, every week. For the first 12 years of my career, that involved what you might consider full scope family practice, that including obstetrics. I've delivered over 450 babies. I did a lot of women's health, kids health, adult health. Nearing the end of that 12-year period, when I was working at federally qualified health centers, I became the chief medical officer of my system of health centers, which was 3 different sites. So that dropped me to about a 50-50 administrative clinical split. When I decided about almost 9 years ago now to join the Los Angeles County Department of Health Services, it was largely motivated by having done a lot on the front lines in neighborhood medicine, you could say, but wanting to apply some of the things that I had learned, some of the principles I had latched onto, and take that to a very large population. And so when I made the move to the county, I had to very consciously give up a couple of things. I wasn't ready to give up clinical care, and so I still see patients 2 days every week. I see adults on one day and pediatrics on another day. But the rest of the time had to be devoted to a greater percentage of time in leadership and innovation. And so that was kind of one of those things. So nowadays, you can find me in clinic on Mondays and Thursdays, and you can find me either working, well, I guess right now, sometimes from home, although I'm in my office right now, or at various ones of our very large system. We've got 4 hospitals, 24 outpatient clinics, 2 very large outpatient specialty care clinics that include ambulatory surgery centers. All in all, something approaching 800,000 patients a year in care.
I'm going to skip ahead a little bit to there's some similar questions, kind of talking about what it's been like being the chief medical officer of Los Angeles County, specifically during the COVID pandemic. Like, how has your role changed?
Yeah, so I believe that one of the primary roles of a system leader like I am is to keep the big picture in mind, keep the principles that the system is built on in mind, regardless of the situation. And so as in a leadership system, in a leadership position across the system, my role is a little bit different than, say, if I was the chief medical officer of a single hospital. So we have 4 chief medical officers of our hospitals and 1 of our ambulatory care network. Each of those in the midst of COVID is largely focused on the direct patient care needs of COVID patients. Attending to surgeon patients, attending to the escalation of patients in our critical care units. For me, since I was not running a single facility, I could step back and look at some of our bigger pictures around making sure that certain populations of patients weren't left behind, making sure that we were attending to our values around equity, making sure that we were attending to our values around trying to prevent patients who didn't have COVID from falling through the cracks. And so what that does is it puts you in a frame of mind to stay in touch with all of the chief medical officers of our different facilities, but also trying to take a deep breath, step back, and make sure that some of the larger system issues are being taken care of, including working with supply chain to make sure we have the equipment and the PPE available to all of our hospitals, looking at the broader trends, what's going on at all of our hospitals, looking at do we have to transfer patients from one hospital to another hospital to help us meet the needs of our integrated delivery network of the 4 hospitals and all those clinics. And so, COVID has certainly done that. It's also required some leadership in specific projects. For example, right now, I'm also leading our effort to get flu shots out to as many of our patients as possible. And in doing so, lay the train tracks, so to speak, for the eventual delivery of COVID-19 vaccination. And so that requires a system-wide coordinating role to do that. Also, when we think about recovery, following the CDC recommendations, you have to reschedule, defer non-essential care, especially in those early months of COVID. And now that our system's starting to come down off of the summer surge that we saw, how do we start very deliberately reactivating services, recovering? And so that's been a lot of the role from more of a kind of a central leadership point.
So you mentioned that in your role, you kind of get to also think about addressing health disparities. Los Angeles is such a diverse place. Can you talk a little bit specifically about ways that you can use your role to do that and sort of deal with any disparities?
Yeah, so when I joined the county 8.5 years ago, one of the things that we noticed was that, like many public health systems, we had a propensity to be siloed. Each hospital was kind of like an independent kingdom unto themselves, and each independent clinic would maybe have a relationship with the local hospital. But what we found was that was leading to a lot of variability in care. Patients were having different experiences in accessing care based on geography. And we didn't like the concept of geographic inequity or inequity based on zip code. We wanted, when a patient had a particular need, we wanted them to be able to have a uniform way of accessing their primary care physician, and then have the primary care physician have a uniform manner in which to escalate their request or seek the input of specialists and specialists system-wide. So that if a given hospital maybe had the retirement of a specialist or a medical leave from a specialist, then automatically that would not mean that all the patients in that particular geography started having a reduction in their ability to access specialty care, but instead we would take the entire system and help to mitigate some of those unique local situations. And so what that's done, even in the context of COVID, laying down those processes to be able to reduce geographic inequity, we've been able to use those same values, those same principles to address COVID, to manage patients across hospitals, to transfer them when needed, to help them access maybe infectious disease specialists or others, to bring together the critical care teams from our different facilities to make sure that we were taking similar approaches in the care of patients. As you might be aware, our understanding of COVID evolved very, very rapidly, continues to evolve. And so being able to share that quickly across our facilities has been an important step. And really, for the Department of Health Services in Los Angeles, it was really an innovation to be able to see ourselves as an integrated delivery network and not just a generalized cluster of unique and fragmented hospitals.
Kind of our next question would be, what have you thought is the biggest change in the relationship between patients and their physicians since you started practicing? How that's evolved?
Yeah. So back in the dark ages, but I did start practicing medicine before the internet, before cell phones. And I would say that the biggest changes that I have seen in the almost 25 years, I guess, since I graduated from medical school, are good things. And they have affected the patient-doctor relationship, but I think in really good ways. Patients in general, because of greater access to information, are more empowered. They aren't purely relying on the doctor to give them all of their healthcare information. Now, granted, not all the healthcare information that they are accessing out there on the web or from blogs or from webcasts or podcasts is accurate. However, it does make them ask good questions. It enhances their medical literacy. And I think that's a really good thing. Additionally, just culturally, as a nation, I think people are more empowered. They are more likely to ask good questions, speak up for themselves. And I think that's good. Patients are asking for more autonomy. It's not just take the blue pill, it'll make you feel better, and nobody asks any questions. And so, certainly as a physician, that is a pivot that I have to make. I have to be aware, right, of that dynamic change, but I've welcomed it. And part of that is the ethos of a family doctor, right? Family doctors approach people very holistically. We see the whole person. Our training is heavy in behavioral health. It's heavy in communities. It's heavy in population health. Viewing patients as a member of a larger population or larger community. And so that transition came very naturally to me. And in general, I think it's a really good thing. I think, some doctors have complained about it. Oh, my patients are always talking about what they read on the internet, or they're always asking me about this thing or that thing. And yes, it changes the dynamic, but how can we say that patients that are have greater degrees of medical literacy feel more empowered to ask good questions of their doctor? How can we say that's a bad thing? And so, it's something I've embraced, but it's definitely been a change since 1996.
So you just kind of mentioned a little bit how your background as a family medicine doctor led very naturally and helped you with your career in healthcare delivery and improving access. Can you talk a little bit about what other general things people might want to focus on or think about if they are in other specialties, but also interested in delivery services?
Yeah, so I think that, for me, the decision for family medicine was based on, kind of my core values, right? And I really think and what I was passionate about. And so I really think that anybody, as they're looking towards what decisions they want to make about their career, how they want to spend their time, you have to have a very accurate assessment of yourself and what it is that you're leaving on the table with any given decision. For example, when I moved from the decision to move from the community practices to the county, I had to make the very conscious decision that I was going to give up some of the scope of family medicine that I enjoyed so much. Didn't deliver babies anymore, didn't do obstetrics, even outpatient obstetrics. Had to split up my days between between adult and pediatric medicine, had to not do quite as many procedures as I used to do. Would I have made that decision straight out of residency? Absolutely not. I came out of residency broadly trained. I was doing colonoscopies and minor surgery, and I was trained to do C-sections as a family doc. That's very unusual. And I did hospital medicine, rounded in the ICU. And I wasn't ready to give that up, out of freshly trained out of family medicine residency in 1999. But in 2011, after having done that for 12 years and seeing and knowing that I only have one career, I only have one life to live, and that I had some ideas and I had some things that I wanted to do for the larger community. Kind kind of had to make that decision. You know, when I was leading a federally qualified health center system of 3 sites, you know, we took care of about 20,000 unique patients a year. Well, you know, now I'm leading a system that takes care of 800,000 unique patients a year. And I remember coming home in my first month or 2 on the job, and I'd been in a meeting that day, and I was relatively new to the county, and but was working to solve one of our more intractable problems, and proposed kind of a radical, new, transformative idea, and talked it out with my bosses, and they said, that sounds like the right direction to go. Let's do it. I went home and told my wife that night. I said, you know, I think I just made a decision today that impacts the care of about 250,000 people. and that was, you know, that was a pivot, but that was what I was looking for, right? I was looking for an opportunity to help impoverished patients, vulnerable patients at a very large scale. And those are kind of those things. I wasn't ready to do that straight out of residency. But 12 years out of residency, I was ready to do that. And one of the things that I would say for all of you is kind of be patient with your career as it evolves. And I'm gonna talk about that in a couple different ways, because these are some things that have been really, really important to me. The first one is to embrace wherever you are at in the evolution of your career, and don't miss it or its opportunities. And here's what I'm talking about. When I was a second-year medical student at Northwestern, at that time, we didn't do hardly any clinical exposure at all. It was just 2 years of just straight lectures. And there were so many of my colleagues that were saying, I just can't wait till I'm out of the lecture hall, and I can't wait till I'm in the hospital. Well, then we got in the hospital. I can't wait till I'm an intern and I finally can start making a little bit of money. And then when they were an intern, I can't wait till I'm, not the junior one on the service, and I get to run a service, and then when they're, finishing and getting close to the end of their residency, it's, I can't wait until I'm an attending physician and I can make real doctor money and I don't have to be a resident anymore. And then it's, I can't wait till I'm not the junior member of the medical group and I always have to work Thanksgiving and Christmas every year, And then, a decade into their career, I can't wait till I retire. Medicine's changed. Nothing's the way it used to be. And I'm so grumpy, but you can see where I'm heading with this, right? There are people who spend their time now waiting for whatever's next, and they miss the opportunity to embrace everything that this moment in their training has to offer. I did things as a medical student that I never did again in my career. On my cardiothoracic surgery rotation, I scrubbed into open heart surgeries and held a human heart in my hand while they sewed on the vascular grafts, right? I will never have done that again in my career. When I was a resident, I did a lot of work in the ER. I ran more codes than I can count. I have run maybe one code since that time, and that was in the first 5 years of my career when I was still doing a lot of hospital medicine. And so all along the way, what I would say is fully embrace wherever it is that you're at for all the good that it has to offer, and try to minimize the burdens, right? Try to minimize the downsides, because there is downsides to being a medical student or an intern or a resident or the junior faculty in the group. But if you can, go through your career maximizing the good about whatever you're in, then I think you're going to be a lot happier. You're going to find joy in practice. And so the first thing, I would summarize that up as just be present wherever you happen to be present. The second thing I would say, and this goes for anybody in their career evolution, is that when I was, and I learned this very early on. So when I went into practice straight out of residency, I kind of had a dual appointment. I was a faculty member for the University of Southern California Department of Family Medicine, and I was seeing about half my time was seeing patients at a federally qualified community health center in the community. And about 6 months into my time at the federally qualified health center, the medical director left. And I was only 6 months out of residency, but already the CEO of the center was starting to approach me and say, "Hey, Paul, would you consider throwing your hat in the ring to be our medical director?" I had a mentor that I had relied on a lot for advice during that time. And I went to him and I said, "What do you think about this? It seems kind of premature, but, I'm a leader type. Maybe I should jump into this." And he said, "Paul, you will never fail to have opportunities to lead throughout your career." He said, "This is not the last time anybody is going to ask you to lead." He said, "Your task in these first couple years of your career is to learn to be an awesome clinician, to be a great doctor first." He said, "That will always be the foundation of your career. That will also always give you the street credibility when you get into leadership." And so I withdrew my name from that position. And sure enough, 2.5 years later, I was the associate medical director of another federally qualified health center. But what that taught me was, whether you want to go into leadership, public health, any kind of clinical practice, all of you are likely at some point to have opportunities to lead, and that's a good thing. But your basis as a leader will always be, in my first and foremost, a great doctor. And so, even now, even when I am only practicing 2 days a week, I still have my colleagues come to me for clinical advice, or "Come see this patient with me," or "What do you think I should do here?" And now certainly a part of that's just because I've been in practice for almost 25 years. But also part of it's because there's a perception that not only am I a system leader, I'm also a clinician leader. And so that is something that I would encourage all of you, is to be patient with your career evolution, whether it's in public leadership. I have a lot of people that come to me straight out of residency, and they want to be my deputy, or they want to be have a 70% administrative role and 30% clinical role. And in general, I've said, look, you're destined for that. You've got an MPH, or you've done a Robert Wood Johnson fellowship for 2 years, and you've done some great public policy research. But I always encourage them, be a clinician. Be a doctor, get into our system, and there will be no shortage of opportunities for you to lead, to craft policy, to do those things. But don't abandon, clinical practice right out of residency, because you will always be better at those other things if you start off as a doctor. I don't know if that answered your question perfectly, Phoebe, but those were a couple of things that I think were related to whether you're a family doc or not.
Could I jump in and ask a question, actually, on that point? Yeah, I mean, I think it's an interesting point that you say to pursue the clinical side first. I just wanted to know, on the flip side, do you ever think it would have been useful to have more like administrative acumen early on in your career that, because I can say there's probably a handful of clinicians or people who go through med school and maybe not immediately pursue clinical side of things and immediately jump to industry or something like that. And I just wanted to get your thoughts on maybe that type of person.
Yeah, I think that along the way, there are opportunities to grow in your leadership skills. A couple of them come to mind for me. So again, I didn't have my first real leadership opportunity until about 2.5 years into practice. And even in that, I was watching, I was learning. Some healthcare leaders are bad examples and some are good examples. Lots of conversations with my mentors. But then what I did when I started getting into leadership was I began to exposing myself more intentionally to thought leaders in medical delivery, to innovators, people who were challenging the status quo, thinking outside the box. And then I had a great opportunity 2 times during those first 10 years to participate in leadership programs, you could say. One was a very short leadership program. It was about 4 or 5 days through the Harvard School of Public Policy or Public Health. Another one was a 2-year fellowship sponsored by the California Healthcare Foundation, where you would take people currently in emerging leadership roles and walk through a 2-year curriculum with them, interspersed with 3 in-person meetings for about 4 days each a year. And that was also a great opportunity, Sid, to kind of start learning some of those things. But again, being a clinician from the start and having that as your priority always keeps the patient in front of you as the number one thing. By being a clinician, you have that those relationships with patients, those experiences with patients, and you never forget that that's why I'm here. Sometimes I worry that if someone goes straight into a type of work that is distant from the patient becomes an idea or a concept or a theory or a research project instead of Jose or Mike or Jane or Maria. And by being in practice, you internalize that. And so that's why even when I took this job, I said, I'll take the job, but you got to let me keep seeing patients. Because in the county, before I came, there were a lot of people that just went into administration. And I said, that's not for me. I said, I'm going to be working on a lot of ways of transforming and improving our system. And I want to be seeing patients along the way to see how it works. And I want people to see me struggling with the same challenges and system issues and patient care issues that they're struggling with. So they know that I am personally invested and personally aware of the challenge that both our patients and our providers face.
If I may jump in here, thank you for talking with us, Dr. Giboney. With respect to your statements on making the most of the seasons that you're in and being present where you are, can you speak a little bit more on that? Because I personally, that's something that I've been kind of thinking on myself, especially this past summer as I was getting ready to start medical school, because I'm in my first year right now. So what ways would you suggest students make the most of their time in medical school specifically, and specifically at Northwestern, since you also went here?
Mm-hmm. Yeah. So some advice I got from a mentor before I started medical school was, he said, Paul, you're only in medical school for 4 years. He said, there's going to be some things, not only just to be successful, but to make the most of it, there's going to be some things you're going to have to give up. And so he said, pick 1 or 2 things outside of medical school that you're going to do that are going to keep you sane, that are important to you. And, but then the rest of the time, invest in growing yourself as a medical professional. And so I very consciously kind of identified what are those things that are going to keep me sane. And then I just really dove into into my training and really did that for, the next, 7 to 9 years. And it was interesting. I remember 2 years into my real practice, you could say, I told my wife, hey, remember that thing I really used to love to do about 10 years ago? I think I'm gonna start doing that again. You know, I kind of got a little bit more bandwidth right now. Even though I was still working maybe 60 to 70 hours a week, you know, that felt like a luxury. That felt like I had a lot of free time on my hand, because residency was more like 90 to 110 hours a week, at least back in those days. That's the way residency was. And so, you know, and so I began to bring some of that back in. But I would say that advice goes for any opportunities in life. So I'm a dad. I've got 3 kids, and parents also have a tendency to do this. I can't wait till they're out of diapers, you know, or I can't wait till they can dress themselves, or I can't wait until they can, you know, do their homework on their own, or I can't wait until they can drive themselves around, you know, and they spend their entire parenting can't waiting until their kids get to, you know, some other stage, and they miss the wonder of an 18-month-old, you know, because they're so anxious for them to get out of diapers, you know. And so, you know, I think that kind of approach to life, and again, I'm talking about finding opportunities to bring joy into life, because I'll tell you, medicine, like some other careers, has a lot of burdens to it, right? You are running that code in the ER and the patient doesn't make it, and you're the one telling the family that the patient is gone, or the cancer diagnosis, or the patient that is so severely depressed they made an attempt on their life. You know, medicine is heavy, and trying to find ways to experience the joy of participating in those sacred moments of life is something. It's a privilege. It's a privilege to be part of those things. And one of the things that kept me going through my first 2 years of medical school was just, man, how lucky am I that I get to devote 18 to 20 hours a day learning this stuff. You know, I've got nothing else on my plate hardly. I get to spend all my time learning this amazing stuff about how incredible the human body is. And so I actually embraced the joy of those long nights and those hard days of study, because, well, first of all, I didn't have any other choice. I had to do it, right? But also I chose to say, isn't this awesome that I don't have to have a side job? I don't have to be working somewhere else. I'm actually full-time in medical school, devoting all my energy, most of my energy, I guess, to learning all this really amazing stuff that most people in the world will never know. And that was kind of cool.
What were the few things that kept you sane throughout your career?
Yeah, so it varies for everybody. In medical school, the 2 things I did was, first of all, I dated and ultimately married my wife. She was one of the 2 things, right? So relationships, right? Important relationships. And it wasn't loads of relationships, right? It was you know, when I got off the plane, when I landed in Chicago, I knew nobody within 800 miles except for a girl that I had just started dating that summer. Well, we've been married 26 years now. You know, and so I said, you're going to be one of my priorities. And for me, my faith is a very big priority. And so I tried to go to church when I could. Right, and that kept me sane. Right, that was something that rooted me. Right, it was something I had grown up with, something that kind of informed my value system, my approach to life. And so those were pretty much the 2 things. I didn't work out nearly as much as I wanted to. I was an athlete. You know, I didn't go to as many baseball games, Dan, as I like to. You know, I didn't read as many fun books as I do now. But you know, those were the things that grounded me, right? Is a relationship with a woman who would become my wife, and my faith.
Well, so you've kind of talked a little about some things that you suggest we should make sure to actively do. Is there anything that you, looking back, wish you had done differently throughout medical school?
I wish that as a poor medical student, I had gone out I'd figured out a way to go out to eat more in Chicago. My wife was was the one who was paying the rent and was putting plenty on loans, of course, and you know, maybe I should have spent a little bit more on food, but no, but really, you know, I think along the way, I should have, you know, perhaps done, you know, a better job at writing down some of my experiences, maybe doing a little bit of journaling, thinking about those things, reflecting, maybe being a little bit more introspective. Some of the stuff I'm sharing with you now is stuff that I've kind of pulled from the cobwebs as I've talked to people, but I didn't really acknowledge all of it at once and at the time. And so I think maybe being a little bit more, I was present in what I was doing and what I was learning, but I wasn't necessarily fully, you know, maybe introspective and reflective on what was happening with me at the time. And I think I would enjoy going back and looking through that. One thing I am really glad I did was I did pursue, and I think this is one of the questions somewhere, was relationships with mentors. Mentors emerged in a couple of ways. The mentor that I have leaned on the most during my career is actually also a Northwestern grad. He's about 10 years ahead of me. And one of my family members just happened to meet him. And they shot me an email and they said, "Hey, Paul, you're a first-year student at Northwestern. I just met a guy who graduated from Northwestern a long time ago. And you know, thought you might want to get in touch." And so I got in touch with him at that time, not by email, by phone, believe it or not. But he was great. And he was just awesome. He was like, he still remains my most influential mentor in my life. And he just embraced me. And I asked him questions. I actually went down and spent a week shadowing him around and learning from him. And so it took a lot of initiative on my end to reach out to him, to pursue him, but also he was just naturally great. At Northwestern, I built, you know, you'd find that attending physician that just was just like everything you always wanted to be, right? And there's so many great docs at Northwestern, right? And so I found a geriatrician who went out to some of the housing projects that were focused on housing for the elderly. And she would go down out there and run clinics and stuff. And I like latched onto her and followed her out. And I found another doctor that was planting a clinic on the south side of Chicago in a very underserved neighborhood. And so I did my, they called it an externship. Between my first and my second year, I spent a month and a half working with him as he began to set up that clinic. And those two people gave me a lot of advice along the way from the Northwestern standpoint. So, you know, kind of pursuing them, identifying people that seem to be kind of like you or to be doing things that are like what you would want to do. And then just kind of learn what their perspectives are, and don't be shy in asking questions. I recall one of the folks I asked a question about, and he didn't answer it for me, but he asked me some really good questions in return. He said, "Paul, before you make that decision, just ask yourself, you know, these 3 questions." And by asking myself those 3 questions, I was able to come to my own decision. But it was all tapping into, where do you see yourself going? What are you passionate about? What are your values? What's important to you? And that, you know, that kind of helped direct me.
Kind of along those lines, can you talk a little bit about the role of networking and getting where you are, and kind of, if you can, walk us through how you got what you got?
Yeah, so I am not a person who has been particularly ambitious for my own career trajectory. Now, you would think, looking on the outside, that I had it all figured out. I had it all planned. You know, here I am, the Associate Chief Medical Officer of the 2nd largest public health system in America. And you would say that, you know, that was all part of the game plan. but honestly, I was always more ambitious about the task and about the mission, and the position followed that. So this is kind of, you know, the way it worked. I was a, you know, staff physician at a federally qualified health center and on faculty at USC. And one of my co-faculty at USC kind of watched me from a distance, and she was the medical director at another federally qualified health center. And so when it came time for her to hire an associate medical director, she approached me and said, hey, do you want to move over to this other health center? And I ended up being there for about 9 years. And then I just grew in my role there, right? And then when she left, I was asked to be the CMO there. So I took that on because that seemed like the best way to use my skill set. And then not actually very long after that, there was a huge leadership change and a mission or refocusing at the county. And I reached out to someone at the county and I said, these are kind of things I've seen from the other side. You know, what do you think where you might use me? And so I'm a family doc, and they hired me as the director of specialty care for the County of Los Angeles. That was my first job with the County of Los Angeles. And you might think, what in the world is a family doc being the director of specialty care? He's not a specialist. But I was the voice of the customer, right? As a primary care doctor for all those years, I was the one always involving the specialists in the care of my patients, right? And so I started doing that, and I said yes to tackling a couple of the most intractable problems that had never been solved in the county for 30 years. And I said, give me a crack at it. And I had some success in that. Certainly haven't fixed everything. There's always areas to improve, but made a lot of progress from the burning platform that I had inherited. And then something else came along. And it was high risk and high value to the system. It was a quality improvement program. I mentioned it in my bio, about 100 different quality measures that were all financially incentivized. And basically what the state government said was they took about $250 million a year out of our budget, and they said, we're going to put all that at risk now, and you got to earn it. What you used to get just by seeing a bunch of poor and needy people in the county, we're going to make you earn. And so they needed someone to lead that. And I said, I'll lead that. And so everybody thought I was crazy because it was so high risk, right? Well, 5 years later, we have gotten 100% of that money. So well over $1 billion over a 5-year quality program. So I said yes to that, and I put my heart and my soul and my energy into it. And about 3 years into that, they said, Paul, we haven't had an associate chief medical officer at the county for a while, but you've had your hand in so many things. In specialty care, you're a practicing primary care physician. You've just helped us have, at that point, 3 years of success in improving 100 different measures and metrics of quality in our system. Well, we want you to kind of grow that and do something more with that and help us out. And so, that's when I got offered my current role. And so none of it was planned. I didn't have my designs, and I don't even have an internal measure of success. A title is not, I've never said, oh, I'll only be successful in my career if I finally reach this kind of title. It's really, my measure of success has always been the ability to make a difference, to improve care for vulnerable populations, and so my ambition for the mission actually ended up being a successful pathway to career as well.
As you've moved up in leadership roles, I imagine you start encountering people who are not medical professionals, who are not healthcare professionals, people in the financing team, legal teams, whatnot. How has that relationship and interaction with non-medical professionals for a healthcare mission worked out for you?
Yeah, they have been some of my greatest allies and partners, because I don't know the finance end of things. I don't know the supply chain things. And one of the secrets I've learned to success in that area is to really value the expertise and contributions that others that non-physicians bring to the table. Everybody's got their own style. I'm a first name guy. Everybody wants to call me Dr. Giboney. Doctors automatically get loads and loads of respect and deference in our system. Even though we've tried over the years, it's still a very hierarchical system. But I still sign every email Paul. I introduce myself as Paul, not Dr. Giboney, unless it's to patients. Obviously, they need to know that I am a competent, leader for their healthcare. But with the supply chain folks and with the finance folks or the pharmacy folks or the quality folks, I'm just Paul, and we're partners. And they have loads of value to bring to the table, as do I. But that's something that. To be honest, most of them still insist on calling me Dr. Giboney. But I'm trying to send them the message that just because I wear the title, that doesn't mean I have, I have all the right ideas. A lot of times their ideas are outstanding. And so that's kind of one of the ways I have tried to interact with them, and just kind of also having the humility to say, boy, you just used a bunch of terms that I have no idea what they mean. Can you back up and, help me understand what you're talking about when you're talking about that particular, part of our business. So I hope that answered your question, just in terms of interacting with other folks.
We don't have too much longer, so if anyone else has any questions, this is a good time to ask.
Oh, can I mention something? Some of the questions were about my work in telehealth, which has been really, really rewarding. And so maybe I'll just jump in on that. So what we found when I arrived at the county was that in this fragmented system, there was really very little opportunity for the primary care doctor and the specialty care doctor to talk with each other, to coordinate care. And so the way that most specialty care access was handled at the time was the primary care doctor would write something down on a piece of paper, hand it to a clerk. It might say, 45-year-old with chest pain, please eval. Hand it to a clerk, and it would go through this really long administrative bureaucratic process of different hoops to get approved and signed off, and then it would get at some point scheduled. And every referral was taken care of the same way through the process. And it was just it turned out that we had longer wait times than we wanted, and really not an opportunity to coordinate care and to improve those handoffs, those transitions of care. And so what we deployed was something we called e-consult, or electronic consultation. And basically what it was if the primary care doctor needed to ask the cardiologist to get involved in the care, we had a secure, medical grade communication platform, and the request would go off to the specialist. Specialist would get an alert that they have a new request, and then they would reply back, and then would ensue this iterative back and forth dialogue about what the next best step was for the patient. And what we found was that, at least in cardiology, about half of the time, the patient never actually needed to take a day off of work, get childcare, take 2 buses across town, or deal with parking, and actually go and see the specialist in person. The cardiologist could review the EKG, review the results of the treadmill test or the echo, review the medication list, the symptoms, and be able to answer the primary care physician's question. And then the primary care physician could implement that into the care of the patient. And that happened over and over again. And we've built, at least to my knowledge, what is the largest electronic consultation system in the world, at least for an open system, a system that is not closed, like a health group or something like that. But what that built for us, and what we did in that, was we also built a relationship between the primary care and the specialist. I've got 14 cardiologists that respond to e-consult requests, but each one of those cardiologists is assigned in a longitudinal fashion to a group of PCPs. So every time a given PCP goes on eConsult, they get the same cardiologist every time. And what that does is it develops relationship over time. They become familiar with each other. They get to know each other, and it incentivizes both of them to invest in a high quality dialogue. And it allows the specialist to kind of get to know that PCP, what the limitations of their practice setting are, what their concerns are. And also it's very educational, because the specialist knows the more they educate the PCP, the better questions they're going to get in the future from that same person. And so what we've done is we've basically taken the second largest public health system in the United States and turned it into a one-on-one relationship. And that's been really great. Is it perfect? No, but it's pretty amazing. It's been a great practice boon. And so that's just one element of telehealth. And in COVID, it was a great benefit to us to be able to have that level of coordinated care, because in a season where you're really trying to limit the number of face-to-face visits in the hospital because of all the social distancing and disease transmission and patients trying to remain safer at home, it was very powerful for the specialists and the PCP to have that kind of conversation. So only those patients for whom an in-person specialty visit was of incredibly high value and a difference maker for them would actually need to leave their house and go to the hospital. So that's one aspect of telehealth we've worked in that's been really transformative for us.
All right, Dan, I don't know exactly what time you want to make sure we get this wrapped up.
Oh yeah, we are right at about an hour. I don't know if you have maybe one last question, or does somebody have a question? Oh, actually, there was one that was put in the chat. Can we finish with this one? Could you discuss the importance or not of having an MPH/MBA in addition to the MD to do the type of work that you do?
Great question. So I do not have an MPH, but I have colleagues that do, and it's great. I don't necessarily regret not getting one. But I always regret not learning more stuff. I mean, learning is awesome, right? You know, so I mean, I would never try to talk anybody out of getting an MPH. I think it's a great asset to the work. You learn a certain set of disciplines and approaches. I think for me, I think I would have feared that if I had gotten the MPH, I might have gone a less patient-focused direction in my career, because I would have thought I have to use that MPH right away. And so in some ways, I guess I'm glad that for me, since I didn't know as much about myself back then, and I didn't know as much of where my career would lead me as I do now. But I think it's great. I think it's great. I don't think it's necessary. I don't, when I'm hiring folks to be part of my team, an MPH is a nice to have. But I'd say the best leaders on my team have not had MPHs. But certainly it's not, they're not better because they didn't have an MPH, just they happen to be better. And so, you know, I think it's great. I mean, I'm certainly, I'm a fan of education. I'm a fan of knowledge and learning and growing and pushing yourself. And so, yeah, I would never decline that. But for me, in my career path, I'm pretty glad I was an operations guy. I was a learning how to get patient care to people in the context of a delivery system. And I don't think I needed an MPH to do that.
Great. All right. Well, let me thank you all for being a part of this special conversation. I hope that you will take the opportunity to join us for upcoming APFs. The next one will be on the 20th, featuring neonatology, which is the first time we're going to do this specialty. So I'm psyched about that one. And Phoebe, thank you so much. Great job moderating. We appreciate you. And Paul, most of all, thank you so much for taking the time. We know how busy you are, but your heart comes through. And thank you for taking the time and sharing and connecting with the students. We really appreciate it.
It's a pleasure. Good luck to all of you. Northwestern was awesome. It was a critical part of my life and my growth. I have all the love in the world for the Wildcats. So enjoy the rest of your medical education.
I had a question. Is there like a email or somewhere we can contact with you if we have more questions?
Dan or Phoebe, feel free to circulate my email among everybody on the call.
I'll be happy to do that.
All right.
Thank you.
Thank
You're
you
welcome.
again. Have a great night. Go Dodgers. Good luck tonight, Paul.
Thank you. Go Blue.
All right. Cheers. Take
Thank
care,
you.
everyone.
Bye-bye.
All right.